Hello and welcome to one more lecture of pediatrics. And in this one, we are going to wind up all the problems which we are studying for the last 3 or 4 lectures, more than that, by the way, about the common conditions of the neonates. So in this lecture, particularly, we are going to discuss respiratory distress syndrome, transient tachypnea of newborn, meconium aspiration syndrome, and then we are going to uh, talk about some more conditions which are related to what you can say, which are the common conditions of neonates. Okay, for example, um, I will talk about a little about the sepsis. Okay, and that's it. Then we are going to move on to some new lecture of pediatrics. So in the previous lecture, I talk about, if you remember, I talk about what is respiratory distress and how we can catch, if anyone have respiratory distress. So if you did not watch the previous lecture, so the lecture which I uploaded before this lecture, you can read about how to see if the infant is in respiratory distress or not. Okay, so the first one is respiratory respiratory distress syndrome. Okay, so talking about the respiratory distress syndrome, what happens is when the babies are born, especially those babies who are born prematurely, um, the problem is their lungs are not mature enough. Okay, and why their lungs are not mature enough? Because there is no surfactant. Okay, so of course when there is no surfactant, uh, surfactants are very important, and they protect the lungs or alveoli from collapsing, and that's one of the reason whenever the babies they born prematurely. So what we give them is uh, we give the mothers before the babies are born. We give them the injection of corticosteroids, uh, two injections, okay, just to make their lungs mature. uh, so uh, if the lungs are not mature, or they don't have surfactant, or they have surfactant deficiency, surfactant deficiency, you know, what happens is they have poor lung compliance. Okay, so when they have poor lung compliance, the lungs can collapse and they can present with respiratory disorders. Okay, uh, now the important thing to understand here is when again, this is too much basic thing. uh, I think if I will go into too much detail of surfactant, of course it is going to take a lot of time. Surfactant is basically a mixture of phospholipids and proteins, and these are secreted by um, what you can say, type 2 pneumocystis. Okay, um, and whenever the surfactant is not secreted in premature babies, it will lead to poor lung compliance. Okay, which I'm talking about before. Sorry, I forget to write about that. And when like they will be absent and there is poor lung compliance, there could be, it can lead to atelectasis. Okay, and there will be decreased area in the lungs for the exchange of gases. Okay, so decreased um, surface area, you can say, of the lungs for gaseous exchange, for gaseous exchange will be there. Okay, of course, which will lead to uh, hypoxia, um, plus acidosis, and which will lead to simply respiratory respiratory depress respiratory distress. Okay, The other name of this condition, which is respiratory distress syndrome, it is also called as hyaline membrane disease. Okay, this is the other name for the same condition, respiratory distress syndrome. So surfactant deficiency, alveolar collapse is there. There is inadequate exchange, gas exchange. If the babies are preterm, they are at high risk. Okay, especially to the babies who are born like before 28 weeks. This is a very very common condition. Less than 28 weeks preterm. Okay, of course, like they are at the most risk. Okay, and it is more severe in boys than the girls. Okay, and it can occur more commonly in the mothers or diabetic mothers. Okay, this one. So what I was telling you, like we give them glucocorticoid injections or corticosteroid injections, antenatally when there is like preterm labor is there. uh, the glucocorticoids, they stimulate the surfactant production. Okay, and they can be protective against this condition. And nowadays, by the way, there is a big advance uh, in the medical science. And what they have done is like they have discovered surfactant surfactant therapy. Okay, so we can give surfactants in the form of injections. Okay, uh, which of course like which can help us in what you can say in dealing with this condition. Okay, so this is a very very big advancement. Surfactant therapy is there. It's a major advance. And how they make it, they basically derive this thing from the pig lung. Okay, and like many researchers they have done, they found that it decreases the incidence of respiratory distress syndrome up to 40% when we give them surfactant therapy. Okay, so simply this thing is very important and very good advancement, okay, of medical science, like we can give surfactant therapy. So one of the thing, uh, whenever there is respiratory distress syndrome, whenever we take the x-ray of the patients, the babies, who have this condition, there is a typical appearance on chest x-ray. Okay, which we can see. I can show you over here, by the way. It shows bilateral pneumothoraces. Okay, it appears like this one. So see, you can see the bilateral pneumothoraces, right, in preterm infants with respiratory distress. Okay, so this is how the chest X-ray looks like. So now, few things, guys. This one is more common in preterm. I told you other risk factors like diabetes mellitus can be there. The women who have diabetes mellitus, they have increased chances. I told you it is more severe in baby boys. Low birth weight, okay, or when there is hypothermia. These are all the risk factors. Okay. So how the patient present, I'm not talking about the clinical features, because the clinical features I already discussed what are the features of clinical respiratory distress. Okay, so any baby who have tachypnea or tachycardia, grunting sounds, intercostal indrawings, nasal flaring, cyanosis, or decreased air entering or in the lungs on auscultation, which we have discussed in the previous lectures. So I'm not going to talk about all those features. So I will just use one word. The baby is in respiratory distress, right? And you would understand what I'm talking about, because that is the criteria which we have already discussed. So the babies, who have respiratory distress syndrome, uh, of course, it appears in the first few hours of life, okay, and uh, it started worsen in 24 to 72 hours, okay, and the child will be having hypoxia. When you will do pulse oximetry, you will find like they have low oxygen levels, as well as cyanosis, which is again a feature of respiratory distress syndrome. So I show you the x-ray, okay. You can found like homogeneous infiltrates, you can found the decreased lung volumes, okay, and mm, you can found like the lungs are completely whitish lungs, and it's very hard to differentiate like the car between the, like here the cardiac border is quite visible, but in most of the x-rays, it's hard to differentiate between the cardiac borders, right? So this is how they present. So how we treat it, okay, how we treat this condition is simply by treatment is done by uh, treatment is done by giving the babies uh, oxygen, okay. Many of they need, they want resuscitation on birth, okay, which we had discussed. What is resuscitation? So we give them oxygen. Sometimes they need ventilation, which could be mechanical, which could be any sort. And I told you one of the good advances is like we can give them surfactant therapy, right? So a very what you can say important thing, or important, you can say, advancement is surfactant therapy, okay. So um, I told you like they are made like the medication one, it is like derived from the calf lung or pig lung, okay, and that's how, and we can give them directly to the baby, and which have very good results in studies. So when the babies, they are born, okay, so we can do some tests, by the way, just to see either their lungs are mature enough or not. We can do the test in the babies, okay, uh, like before the baby is born, just to see either their lungs are mature or not, okay. So like based on that, they decide like either it's good to um, what you can say, go for the delivery, or it's like we can wait and we can still give them injections to make their lung mature. What they do is, by the way, uh, is there is a test called as LS ratio, okay. There is a test called as um, LS ratio. So what is L? L is basically lecithin, and what is S? It is sphingomyelin. Okay. So we check the lecithin to sphingomyelin ratio. Okay. So they take the amniotic fluid, they see the L to S ratio, and this ratio basically tell us either the fetal lung are mature or not. Okay. Or either the lungs have enough surfactant or not. Okay. So this lecithin to sphingomyelin ratio is a marker of, you can say, fetal lung maturity. Is the marker of fetal lungs maturity. Okay, so it works this way. Okay, so Whenever this ratio is more than 2.4, it indicates like the lungs are mature, and the baby is at very low risk of uh, respiratory distress syndrome or infant respiratory distress syndrome. Okay, so this is one of the things. So simply, surfactant therapy is very good, and it decreases the alveolar surface tension, it improves lung compliance, and it maintains the function residual capacity. So this is the treatment. How we can prevent this condition, guys? Prevention is good than treatment. So prevention uh, can be done by prenatal corticosteroids, okay, steroids. So they give two injections, okay. Two doses are required, okay. 24 hours apart, okay, 24 hours apart or 12 hours apart, okay. So it is like most of the time 24 hours apart. Two injections are given, okay. And especially in those who are less than 34 weeks, guys, because 34 weeks, after 34 weeks the lungs are mature. So we can check the LS ratio. When LS ratio is greater than 2.4, or you can simply remember, the ratio should be, LS ratio should be greater than 2:1, okay. When it is like greater than this, so of course it shows like the fetal lungs are mature, okay. So we can go for the delivery, very low chances of getting any complications. So lecithin 2 sphingomyelin ratio is used, okay. So what are the risk factors of having this kind of condition? Is um, like the complications, you can say. Remember broncho pulmonary dysplasia, which we have already discussed, okay. Which have, if you remember, which have a definition, or which is also called as, the other name is chronic lung disease. And if you remember, we talk about this condition, like if the child have the requirement of oxygen or ventilation for so long that you cannot wean them off from the oxygen, we named the condition as bronchopulmonary dysplasia. Okay, so other condition which we are going to study is called as TTN, or transient tachypnea, tachypnea of newborn, okay. Now, as the name shows, guys, it is transient type of condition, right? There are many other conditions, by the way. There could be pneumothorax, but I'm not going to discuss all these conditions because you know what is pneumothorax, right? So, bronchopulmonary dysplasia we have already discussed, okay, and just now I told you about hyaline membrane disease, or transient, like RDS, respiratory distress syndrome. Transient tachypnea of newborn, as the name shows, it's transient. It's a short-lived condition, okay. And this is the most common cause of respiratory distress. Is the most common cause, okay. And what is the cause of this thing? Like whenever the babies are born, as I told you, when they pass through the birth canal, there is a squeezing pressure on their chest, and because of that squeezing pressure, what happens? Most of the fluid which is present in their lungs is basically drained off, comes out. The one which is left is basically absorbed by the lymphatics. So simply this condition arises because of delayed resorption of fetal lung fluid, okay. So what happens is the accumulation of fluid in the peribronchial lymphatics and vascular spaces basically lead to tachypnea, and when this fluid is resorbed after some delay, the condition is gone. So the fluid which is still in the peribronchial lymphatics and the vascular spaces are there, that gives a transient, a short-lived tachypnea, and that's why the other name of this condition is also wet lung syndrome. This is the other name of this condition. Okay. And C, the normal vaginal delivery in which the baby is passing through the birth canal gives some sort of protection because there is squeezing pressure on the lungs. Okay. So there is some sort of protection in normal vaginal delivery, but when the babies, they are born through cesarean section, okay, they are at risk of getting transient tachypnea of newborn. So you can say more common in cesarean sections. Okay. And like respiratory distress syndrome is a condition of preterm babies, but this one usually occurs in term babies, term and you can say post-term. Okay, so this condition is not a condition of preterm babies, rather this condition is the condition which affect most of the term babies as well as the post-term babies. Okay, and the condition basically usually settles within the first day of life. Okay, but some of the time it takes like few days or several days to resolve. Okay, and how we make the diagnosis of this condition is by excluding the other conditions. Simply we have to exclude the other conditions. Okay, the risk factors are maternal diabetes mellitus as well as maternal asthma, again male sex, okay, or baby boys, macrosomia when the weight is more than 4.5 kgs, and cesarean section is one of the risk factor. Okay, and all these are the risk factors: macrosomia and late preterm deliveries, okay, all these are the risk factors for developing transient tachypnea of the newborn. So as I told you guys, like this one is the diagnosis of exclusion, you can say, because we have to exclude all the other causes. So what will be the clinical features? Again, you have to remember all those clinical features which I already talked about in the previous lecture. There will be tachypnea within the first few hours of life. There can be retraction, there can be grunting, there can be nasal flaring. But in this one, often there is no hypoxia or cyanosis, right? Of course, like there is no hypoxia or cyanosis. So chest x-rays are mostly not done, but whenever it's done, we can found perihilar infiltrates. Okay, we can found this kind of findings in these patients. Okay, the treatment remains supportive. Okay, because the condition is self-resolving. If the patient is if the patient have hypoxia, oxygen, if hypoxic. Okay, and very few people, they need ventilator support. Very few ventilator support. Okay, very few babies, they need this one. Okay, and just rest is all supportive, guys. Supportive care is needed. Give them IV fluids if they have less. Give them NG feeds if they are tachypnic and they cannot tolerate oral feeds, so they give them that thing. Okay, so the complications are not so much, but very few of the babies, they have hypoxia or hypercapnia or acidosis, and recovery is usually in 24 to 72 hours. Okay, so very good chances of recovery in these patients. Okay, and the last condition is Meconium aspiration syndrome. Okay, Meconium aspiration syndrome is the last condition. So you already know the story of the meconium, guys. What is the story of the meconium? That the meconium is passed before birth in meconium. Meconium is passed before birth in 8 to 20% of the babies. Okay. It is rarely passed by preterm infants and occurs increasingly as the gestational age is greater. So mostly in postterm babies, right? So when it's a postterm babies, it can occur in 20 to 25% of the babies. Sometimes it is as a result of fetal hypoxia, and the babies can inhale that thick meconium and they started gasping, and they, because of this aspirated meconium after delivery. And guys, this meconium is a lung irritant. Okay, so see, the meconium can cause what kind of things meconium can cause. Meconium, though it's sterile, okay, meconium, it's sterile, okay, but see, it can cause airway obstruction, okay, as well as it's irritant to the lungs, so it can cause chemical inflammation or pneumonitis, okay. It can cause chemical inflammation, or if we say pneumonitis, okay? It can cause chemical pneumonitis, okay. It can also inactivate surfactant, okay. It can also inactivate surfactant. Very, very, very important thing, guys. It can also inactivate surfactant. So see, all these things, like this meconium aspiration syndrome can cause. Or you can say this is the pathophysiology. I write in few of the lines, okay? So what kind of babies are most affected? Term and post-term. So see, we started from preterm, then we come on term and post-term, and this one is surely mostly in the post-term babies, okay? So the lungs, basically have become, the risk factors, of course, is post-term babies, in this case. So the lungs in these babies, they become full of meconium, okay, and the lungs are overinflated. We can see patches of collapse and consolidation on chest x-ray, okay. There are higher chances that the babies may have pneumothorax and pneumomediastinum due to leakage of air, or due to leak of air from the lungs, okay. So these all things are present. So the risk factors are simply post-op deliveries, and what is the clinical presentation? It seems it remains like the babies, they present with respiratory distress. Okay, they present with respiratory distress, and they may have barrel chest because of hyperinflated lungs. Okay, they may present with barrel chest. When you will try to auscultate their chest, you can hear crackles on auscultation. Okay, auscultation, you can hear crackles. So the chest x-ray findings are same. When we go for chest x-ray, we found the same things like hyperinflation, as I was talking about. Maybe you can find patchy atelectasis. Okay, sometimes pneumothorax can be there. Air leakage can occur. Pneumothorax can be there. So very, very, very important condition, guys. This is so how we what you can say, how we give them treatment, or how we treat them, or what is the treatment in these patients, is simply resuscitation is needed most of the time. Okay, uh, we can give them oxygen. Okay, ventilatory support sometimes can is needed. Okay, sometimes if the surfactant is inactive, so we can give them surfactant therapy can be given. And ECMO, extracorporeal membrane oxygenation, a very expensive type of treatment, but sometimes it is needed because severe meconium aspiration syndrome, guys, is related with mortality, high mortality. So how we can prevent this condition is by uh, you can say by suction uh, below the vocal cords, below the vocal cords. Okay, vocal cords, of course, like to remove any meconium, and by avoiding um, postpartum deliveries. Okay, so the complication remains the same. Hypoxia can occur, hypercapnia can occur, as well as acidosis can occur. Okay, and pneumothorax can occur. As I told you, like the lungs can become leaky. Pneumomediastinum can occur as well. Okay. See, chemical pneumonitis can occur. Okay, very important. And inactivation of surfactant can occur. Respiratory, the last thing, respiratory failure can occur. Very important, right? So the mortality of this condition remains high. The mortality, of severe, you can say, of severe meconium aspiration syndrome is up to 20%. Okay, 20% of the patients, they can die because of this thing. Meconium aspiration syndrome, they can die. So that's all about, guys, this meconium aspiration syndrome. Then see, there can be, what is the treatment of pneumonia? Sorry, pneumothorax. And by the way, pneumonia can also occur in newborns, especially when there is prolonged rupture of membranes. Whenever the babies are delivered, there is rupture of membrane, but sometimes the rupture of the membrane occur far before the birth of the baby, and sometimes after rupture of membrane, the amniotic fluid and the membranes can get infected. We call that condition as chorioamnionitis. Chorioamnionitis, okay, which is the inflammation of chorioamnionitis, which is the inflammation of the amniotic fluid as well as the membranes which are in which the amniotic fluid is contained. So chorioamnionitis. So whenever there's prolonged rupture of membrane, chorioamnionitis can occur. So they have higher chances of getting pneumonia. Okay. But the same thing, we deal pneumonia in the same way by giving antibiotics, broad spectrum antibiotics, especially in the babies. So pneumothorax can occur, even milk aspiration can occur, especially in the preterm infants, who have some respiratory depression or neurological damages there, like while feeding, they may have milk aspiration. So this thing can occur. What is the final thing? Of course, like all these babies, they may have chronic lung disease or pulmonary hypertension, and ultimately respiratory failure can occur. So all these things can occur. There are other causes of respiratory depression as well. For example, we just talk about three conditions: transient tachypnea of the newborn, meconium aspiration syndrome, as well as the um, respiratory distress syndrome of the newborn, right? So pneumothorax can cause, milk aspiration can cause, diaphragmatic hernia can cause respiratory distress syndrome, or a child with respiratory depression. Diaphragmatic hernia can cause, tracheoesophageal fistula can cause, airway obstruction can cause, pulmonary hemorrhage can cause, congenital heart disease can cause, and severe anemia can cause. So many conditions can lead to this condition. Okay, so that's all about what you can say, uh, the the common conditions of the newborn. One of the condition, guys, sepsis can occur in the newborns. Okay, we see like the sepsis is occurring early after birth, what you can say early onset sepsis is there, or you can say late onset is there. Okay, and what is the division between early onset and late onset is like any sepsis which is occurring within 72 hours or less than 72 hours. Okay, and this one, the late onset, is like more than 72 hours has passed. Okay, so when we are talking about neonates, so remember after 72 hours but within 28 days. Okay, it is called as the late onset. So whenever it is early onset, there could be few of the reasons. For example, within 24 hours, for example, within 24 hours can be due to vertical transmission. Vertical transmission means what? From mother to baby, right? And after that, it could be due to other conditions. So see, like whenever the mothers have some maternal infections like, UTI, or they are like group B streptococcus positive mothers, okay? Or for example, the mother have fever, or for example, there is prolonged rupture of membranes, okay? Prolonged rupture of membranes is there. Prolonged rupture of membranes is there. All these things, they can lead to increased chances of giving the newborn infection from the mother. So what organisms are there? Think about, in the first 24 hours or less than 72 hours, if the infection is there, think about the group B streptococcus. Think about, like, from the UTI, think about E. coli. Okay. Think about listeria. These are the most common organisms, These are the most common ones which can cause sepsis in the newborn. And whenever it is late onset, guys, okay, after 72 hours, so it means like it is acquired after birth, okay, not from the mother. And this is like, these are the babies who are in neonatal ICUs, okay. And most commonly, the pathogens which we see in these patients or in these babies is basically staphylococcus, because if it is acquired from the hospitals, or it is group B streptococcus, or it could be anaerobes. Okay, it could be E. coli, of course. It could be Klebsiella, and many others, by the way. So whenever there is sepsis, now the important thing to understand here is what, guys? In the babies or in the neonates, in the newborns, there is no reliable indicators of infection, especially in the infants, in infants who are less than 3 months of age. Okay, like in the adults, whenever they have sepsis, what happens is, they present with fever, they present with chills and rigors, they present with all these features, right? In infants, especially in the babies, who are like less than 3 months of age, there is no reliable indicators. Okay, so we cannot rely on these things because, for example, they can present with hyperthermia or fever, but they can also present with hypothermia. They can present with tachycardia, they can present with bradycardia, they can present with respiratory distress, they can present with cyanosis, they can present with irritability, they can present with lethargy. Sometimes they present with poor feeding, sometimes they present with abdominal distension, vomiting, hypotonia, seizures, jaundice, hepatomegaly. They can present with any feature. Okay. One of the very specific findings which we know is like, especially when they have WBC count of less than 5. Okay. So what I'm saying, like the sepsis in the infants, there is no reliable um, indicators, which we have. So simply, whenever we have any baby who have sepsis, we go for septic workup. I talk about this thing many times. What are the things we go for? We do in septic, because we don't want to miss any focus of infection in the babies, right? So we go for septic workup. We do a CBC. Okay. We do a chest X-ray. We do a blood culture. We do a lumbar puncture. Okay. If there are signs of meningitis, we do a urine culture. And if needed, we can do a stool culture as well. Okay. If needed, we can do a stool culture as well. Okay. So this is how we proceed, and then we go for the antibiotic treatment, of course. Uh, so, uh, like we go for septic workup in the patients, okay, in the babies, and then whenever we treat any infection in the babies, we treat it like by giving, um, by covering all the possible organisms. We give them uh, uh, to cover the gram positive plus the gram negative bacteria plus the anaerobes. Okay, so we give them, for example, a very important drugs which I worked in pediatrics. So what I've seen, like they give them penicillin plus for gram positive plus gentacin, okay, or aminoglycosides simply to cover the gram negatives plus metronidazole, okay, or if not metronidazole, then we can give them clindamycin or drugs like this. Like simply we have to cover gram positive, gram negative anaerobes. So that's all about the septic workup and treatment. Okay, there are many skin conditions, guys. I would recommend you, like when you will study in dermatology, pay attention. For example, when the babies are born, sometimes they have, when they are exposed to cold, they have small mottling on the skin, which is a type of a vasomotor response. And this is called as cutis marmorata. Okay, when the babies are born, they are covered in a soft white cream. Okay, they are covered in a soft white cream. Okay, so the first condition which I told you, which is due to, which is a vasomotor response, okay, you can Google these things and you can see the photographs. Okay, you can write this thing, cutis marmorata. Okay, so this is a vasomotor response, which is seen when they are exposed to the cold. And when they are born, they are covered in a soft creamy whitish layer. Okay, that is called as vernix caseosa. Okay, so see, caseosa means like whitish creamish like thing. Many babies, when they are born, they have slate gray macules over the lower back and the buttocks, which looks like a bruise, like someone have hit on them. Of course, hard to see in the dark skinned babies. It is called as Mongolian spots. Mongolian spots. The technical name of that, the medical name of that thing is congenital dermal melanocytosis. Okay, so you can see these things. So some of the babies, they have a small, firm, white, pearly papules, you can say, around the nasal bridge called as milia. Okay, so you can see these things. Search for salmon patch as well. Okay, search for erythema. Sorry, erythema toxicum. Okay, on Google. So erythema toxicum is basically yellow white clay papules, which are surrounded by reddish area. That's what is called as erythema toxicum. It's a very common rash. It resolved by 2 weeks of age. Okay, so you can see these conditions, dermatological conditions online on Google, or if you have any atlas of dermatology. So thank you guys for listening, and we will see you in the next lecture.